started this session, session sort of near and dear to my heart, which is why I got to choose myself to moderate it. First up, we have Dr. Chancellor Gray from the University of Florida talking about bundled care and value-based payments.
Well, good morning, everyone. As Derek said, I'm down at the University of Florida. My name is Chance Gray. I have no financial disclosures that are relevant to this talk. I did want to start by thanking Dr. Vail and Derek and Jeff and the committee for inviting me to come out. I was here at UCSF about 5 years ago, and the time that I spent here really had a profound influence on my career and especially my early part of my career. But the relationships that I built here have been really meaningful to me, and it's really nice to be back among this group of great folks. By way of a secondary disclosure, because of the relationships that I built out here, I've spent a lot of time talking with Dr. Bozick, who's no longer here, obviously, is now down in Austin, but was here when I was here, about value-based care, and I will share that he has influenced my thinking on this pretty profoundly. So I think you all should know that. So why do we care about value-based care? Well, I think there are several reasons that this topic is important now, and probably the first one, and that's immediately relevant, is that we've been very successful at recruiting patients to come to us. We offer surgeries that give people a lot of relief, but because of our success, we represent a pretty big line item for most payers, especially for CMS. Hip and knee replacement is the biggest line item budget for the Medicare budget every year. So they are looking at ways to enlist us to be partners in saving money. So they expect us to care about this. Value-based care they look at as a big opportunity for savings. Second, because of that, there are big financial implications as they transition to more of these value-based purchasing models. Depending on your arrangement in your health system, whether you're in a BPCI or a CJR or some other bundle, that risk, the finance in this whole thing either affects you directly or your practice directly, or if you're in a mandatory model, it affects your health system where you admit your patients, and they're going to expect you to care about it. But then even from payers, payers are looking at more opportunities to introduce these value-based models. And so they may begin shunting patients either to you if you're amenable to being a partner or away from you if you're not, as they investigate more of these models. And so you may see some of your practice referral patterns change because of that. And then finally, I think it's important to reflect that this is all really about doing what's the most patient-centered, and value-based care is inherently patient-centered. If you're delivering better outcomes at better costs, that's by definition patient-centered. So these are also important. They're really here to stay. Of all the things that are happening politically right now, one of the few bipartisan agreements that has been reached in the last few years is on the concept of transitioning Medicare away from being a fee-for-service purchaser of services. So they really care about trying to tie more payments to quality. I mean, you can see there's not too many things that have had a 92 versus 8 vote in favor in the last few years. And even with the election of Trump in 2016, a year after MACRA, these things haven't changed. It's still viewed as very much a bipartisan win because it's saving money and it's improving care. And you can see here MACRA, when it was implemented in 2015, one of the express goals was to shift to more quality-based and value-based purchasing. And you can see in 2011, a lot of Medicare's payments were just done strictly on fee-for-service. But now, as of 2018, almost 90% of their payment model is away from pure fee-for-service. So there's a lot of tie to quality. Just to take a step back and make sure we're all on the same page as far as our definitions, I'm sure you've all seen this. This is the value equation in healthcare. But I want to make sure we're all sort of looking at things the same way. When you talk about value, you're talking about improving quality or reducing cost, or ideally both. And the way we've tended to define quality has been outcome and experience, and cost we've defined as direct and indirect cost. Well, cost is very tricky to measure, and I think one of the things to look at here, we really are looking at episode of care costs. So not just the facility costs, but the cost for 90 days or whatever set episode you want to look at. And then as far as outcomes, to one of the points raised earlier, I think patient-reported outcomes do play a big role in this setting because we really want to know we're delivering value for our patients, not just for what we have decided to value. And they give you a good quantitative opportunity to measure your outcomes. So looking a little more at PROs or PROMs, how are they used currently? Well, right now, as far as most value-based arrangements, they're really a process measure. So this is something you either do or you don't do. Either you collect PROs or you don't, you submit them or you don't. And depending on whether or not you do, you either get quality points and a potential bump in your payment or not. But in the future, I think that's going to transition. CMS has looked at, in the year 5 of CJR, actually introducing PROM numbers as an appropriateness criterion evaluation and potentially even as an outcome measure. So this is data actually published out of UCSF several years back. The graph on the left of the screen there is actually looking at Coos Junior scores and the likelihood of a meaningful improvement. So as you can see, there's some suggestion that you can make some appropriateness decisions based on your pre-op Coos score. A patient who, let me see if I can get the laser pointer here. A patient who has a pre-op Coos of 80 to 90 has a very low likelihood of seeing meaningful improvement from a knee surgery, represented by that blue dash line. And I think you want to know that ahead of time. CMS is probably going to pay attention to that. That graph on the right looks at the darker blue hexagons are actually a high likelihood of improvement. These are patients that have a high mental score and a low functional score. Those patients are likely to do well. The patients in the upper left who have high function and low mental scores are unlikely to do well. When we look at using PROs as an outcome measure, it's interesting. California, you guys have been very proactive in this. This data has been collected since 2012 and published publicly since 2015. And actually, right now, it's available on a hospital-by-hospital basis to see how many patients we operate on experience a meaningful improvement after surgery. And there's even star ratings given. Now, this was data from back, I think this is 2017, American Joint Replacement Registry. And so everybody got a 3-star rating. But that's likely to change as we go forward. And at some point, it's likely that there will be surgeon-specific data available in this regard. And I think it's better to be proactive and know this ahead of time and be prepared to deal with it. How are the CMS bundles changing in the next few years? Well, it's a little unclear right now, and Dr. Barber may speak to this a little bit shortly, but we know that CJR ends a little bit over a year from now. It was a five-year period. We're actually coming up on the end. BPCI has transitioned into the BPCI Advanced bundle now, which is a slightly different model. They're just beginning to launch their second cohort next year, but we don't really know what's going to follow that. We don't know what's going to follow CJR, but we do know that through the CMMI, CMS is really trying to transition away from this fee-for-service model. Additionally, we're really growing the role of bundled pricing outside of Medicare in the CMS realm. We are seeing a lot of private payers, so the Blues in many states have introduced these bundles, Pennsylvania, Florida, North Carolina, California. United Health has a pretty advanced bundled payment network that it's beginning to grow to offer to more providers because they've seen success from it. Humana has a program like this. Many of these private payers are introducing these programs. So they're relevant beyond just CMS. There's a lot of enthusiasm. There's some potential downside to bundled payments that I think many of you are aware of, but we'll take a minute and look at these. So one is obviously physicians aren't thrilled about two-sided risk. So we like the idea of one-sided or upside risk. When after about 2 years, CMS scaled back CJR, and left about 35 of the designated areas had to stay in, but 33 were allowed to opt out. And I think of those areas, a very small number, less than 5% of hospitals that got the option to stay in, stayed in. So when people were given the choice, they dropped out. And then that graph on the right represents ACO adoption. And you can see that the blue bars are the single side or upside risk models. Those were adopted much more readily over that 5-year period compared to the two-sided risk, because people don't like having the risk of loss. We're all risk averse. So that's one big downside to bundled payments. But I think probably the bigger and more important one is this concept of the race to the bottom. So one of the things that you could say we're doing is we're basically competing with our peer group to discount our services. And ultimately, that comes at a cost to us. You may win in the short term, but in the end, you've basically just won a race to the bottom. So I think there are opportunities for improvement in that regard that we'll talk about here in a moment. So just sort of in summary, what most value-based care models have now, and this is CJR, BPCI, et cetera, they're all still fee-for-service based, basically do business as usual, and at the end there's some retrospective review of your costs, and then you can either gain money back or pay money back depending on how you fared. So it's still business as usual. The payers haven't had to dramatically change what they're doing. We haven't had to dramatically change what we're doing. We've just had to be cost conscious. But at the end, the prize is still for undercutting cost, and you have this race to the bottom. So what would a better bundle look like? Well, I think ideally it would start by rewarding long-term outcomes and not be focused just on the short term. There's this concept of treatment agnosticism. What does that mean? Well, right now, if you are getting ready to do a total knee replacement on a patient and they have not failed non-operative treatment, in other words, you haven't demonstrated to their payer that they've had injections, physical therapy, bracing, they may deny payment for a total knee. Well, this gives the opportunity, if you are in a treatment agnostic bundle, to say, look, we're going to do the most high cost efficiency, high impact treatment right away when we know it works and the patient needs it. We can avoid some of these extra expenses along the way. I think in an ideal bundle, we'd have the opportunity for value sharing or gain sharing. So in other words, if we find a way to build in value where we save money for the payer, we improve outcome for the patient, ideally that should be recognized and rewarded with some sort of financial benefit to the practice or the physician or the group. And then also one of the things we think could really be improved is this concept of shared decision making. So there are some patients, as I said earlier, if you have a very highly functional knee, you may not need a total knee replacement, even though your x-rays show you need a total knee replacement. So having a very informed discussion where a patient can look and see, okay, what are my odds of really benefiting from this treatment, and make a decision together with their surgeon, I think that would look much better for our opportunity to provide value. So one of the ways that this can be done, and what's being tried right now in Austin and to some extent at Duke and in a couple other places, all with some slight variations, is this concept of a condition-based bundle. So a condition-based bundle, rather than being a surgical episode, looks at just treating hip pain or knee pain in this instance. So it moves upstream in the care cycle. The goal is to identify these high-impact, maximal impact interventions that are cost-effective early, and to equip your entire team in a very multidisciplinary approach to deliver high-value care to the patient, with each member working at the top of their license. And then ultimately, these condition-based bundles have sort of measured their success through PROs, so looking and seeing, are we actually making a functional improvement in our patients? And I'll talk a little bit more about these. So how does this work? Well, at least at Austin, the way they've designed this is as soon as a patient is identified as needing to see a specialist for their hip or their knee pain, they sort of trigger one of these episodes. At that point, when they are designated as a new patient into this system, they receive a battery of these sort of PRO instruments. And the PROs are designed to identify, number one, the severity of the disease state, number two, whether or not they're at high risk for having a major mental health episode in the short term, and three, their overall functional status. And this helps to sort of triage the patient into whatever appropriate treatment modality. So a patient, for instance, who may have high severity of disease but has major risk for a major depressive episode in the short term may need to see a mental health professional before they undergo a total knee replacement. And so it's built to identify this. The patients are then seen by an extender and evaluated. And so this isn't cookbook medicine. If you score a certain PRO, it's not that you can't see a surgeon. You spend time with the extender, and they may ultimately decide to refer to the surgeon, but they may not. They may ultimately have the opportunity to get you sort of triaged in another direction before you meet the surgeon and improve your likelihood of success. And so we really want to identify that high-impact provider. So obviously, this is a very different way of doing business, and there are some potential challenges. One is a very different payment structure. This is not fee-for-service. This is not billing as usual. You have to negotiate these things up front. Number two, I think people have expressed some concern for patient dissatisfaction. So if you're a patient and you've been told you need to go see a knee specialist for a knee replacement, and you get there and you're told, oh, well, actually, we're going to have you work on weight loss and meet with a mental health counselor, there's the potential for dissatisfaction. But I'd actually argue in this kind of an arrangement, this is maybe better. We all see patients in this setting where we say, well, yeah, I'm your knee specialist, but I'm not going to offer you a knee replacement today. You need to improve X, Y, Z. Those patients are dissatisfied as well, but in this arrangement, we're actually giving them the opportunity to meet with those other providers and work on these things without sort of pushing them away and saying, go back and talk to your primary care doctor about weight loss, et cetera. This is a very data-heavy process, so you have to be ready to deal with a lot of data, both upfront and post, after the care episode is initiated. And then there is two-sided risk here. So there's the potential that as you negotiate these payments, you could stand to lose, financial incentive through this. But that's another reason the data is very important. You need to know your costs very clearly upfront. So just in conclusion, I think one of the things that value-based care is really all about is about aligning goals. And we as physicians or care providers and our patients all want the same things. We want to deliver very high quality care that's very efficient, and we want to have good outcomes. And the ideal that really is underpinning all of value-based care is that thing, is aligning all the teams to work towards those ends. I do think that it's important that high quality care should be recognized and well compensated, and I think that these value-based arrangements actually lead to opportunities for that. So in conclusion, value-based care does currently and probably will continue to enjoy strong political support and payer support, so it's unlikely to be going away. I do think these are big opportunities for physician autonomy. We have conceded a lot of autonomy to administrators in a lot of ways, but I think this is an opportunity to reclaim some of that autonomy. Data is very important as we go through all this, and I think probably a theme overall is improving our data and our transparency and our understanding of what we're doing and how it makes a difference. And this does require rethinking of our key billing and care delivery models. So we should be open-minded about rethinking a lot of these things. So with that, I'll stop and leave you with this slide from Dr. Porter, or Michael Porter, who's a PhD at Harvard, about ways we can solve healthcare. It's pretty broad, but this idea of the integrated practice unit and the condition-based bundle is a big potential successful way to do that. So thank you all for your time.
All right, next up we'll have Dr. Huddleston come in to us from Stanford to talk about registries and whether or not we're really paying attention yet.
Thanks, Derek. Good morning, everybody. Chance, I really appreciate your enthusiasm for opportunities for improved physician autonomy. All right, so Derek asked me to speak about registries and are we listening? So I'll give you some insights into that. The relevant disclosures here are that I serve on the data committee and also the steering committee for the American Joint Replacement Registry, and I was the chair of the California Joint Replacement Registry and one of the founding institutions. So I'll give you an update on the AAOS registry program as a whole. It's expanding, which is exciting. We'll drill down a little bit into the current data on AJRR. And then I will give you a update on the California data that's in the AJRR, and I'll attempt to answer the question, are we listening? And I think the conclusion is yes, we are actually listening most of the time. So this is an overall overview of all the registry efforts. This is a core academy strategy at this point, and the goals are to collect unique clinical information demonstrating real-world practice, enable performance measurement for physicians, by physicians, and then facilitate national registry-driven QI programs, and also support novel research. So those are lofty goals, but we are making progress. So just to back up and give you some of the highlights, so AJRR was reacquired by the Academy in June of 2017, formerly in October of 2017. The Shoulder and Elbow Registry was launched in 2018. The Musculoskeletal Tumor Registry was launched just this past December, and I'm happy to report that the Trauma Registry is taking shape nicely, and there's a formal agreement now between the Academy and the American Association of Neurologic Surgeons for the Spine Registry, which is coming, and that's no small feat. So big news recently, we obtained access to Medicare claims data last summer. The data is not as clean as we would like, so it's requiring a lot of resources to sift through it and make heads or tails, but we are making great progress, and this will give us great information on things like revisions and complications. We've been selected for a National Evaluation System for Health Technology Coordinating Center grant, and this will allow us to participate in the feasibility of using pilot for data linkage from private payers. Right now, our data certainly in terms of comorbidities and complications of patient-reported outcomes don't include much data from the private payers. Recently, we have launched the Registry Analytics Institute, and this is an effort to further disseminate the data, which we are excited about. And we have continued investment in technical infrastructure. That's a big part of the budget from the Academy. This has allowed us to develop dashboards for patient-reported outcomes. And you can see surgeon-level data comparing yourself to national benchmarks at this point. And we have various partnerships with the American Board of Orthopedic Surgery, the Joint Commission, and also CMMI, and these can help you with things such as maintenance of certifications, becoming a center of excellence, the MIPS program, and more. So this is the structure. Here's the board of directors, and there's a ROC, or a Registry Oversight Committee, and then you can see the American Joint Replacement Registry, which is hip and knee, and then shoulder and elbow, which started with shoulder arthroplasty and now has cuff repair and elbow arthroplasty. And then the musculoskeletal tumor registry has been launched, and as I told you, spine and trauma are coming soon. This is just confirmation of the American Spine Registry. So participation-wise, I think the numbers you should come away with on this slide is that it's growing tremendously, and now approximately 30% of the United States total joint arthroplasty volume is contained in the registry, so we're very proud of that. So it's roughly 1,000 sites that are submitting data, 10,000 surgeons that are submitting data, and we're close to 2 million procedures in the registry at this point. So on an exponential upswing. We certainly are using these data for advocacy support. So just a couple of things that we did. We have expanded the data sources for, as I said, with the ResDec, our claims data coming in. And then we are participating in the Physician Clinical Registry Coalition and other things like the Ortho Clinical Research Network and things like that. So on the advocacy front, we're in good shape. We are currently going through a reevaluation process requested by CMS and informed by the RUC, as many people know here, and we've used some data for the registry to help us with that. Registry efforts are going to be key going forward for this transition from fee-for-service to fee-for-value. And we are providing data for reuse opportunities, so this is things like blue distinction in the Joint Commission. After years of trying, we have been able to formally acquire a waiver for prior authorization for hip and knee replacement for Blue Shield of California for folks who participate in the American Joint Replacement Registry. So that's helping us as well. We're very excited about the claims data that we have. These are some survivorship curves looking at femoral fixation that we published last year, but their claims data are what allowed us to provide these survivorship curves. So that was a big success. And at the end of the day, the question is, as surgeons, how are you going to get into this data and how are you going to use it? And I think this is very important. We have 3 ways to do that. And if we don't use the data as surgeons, it's not going to be used as much as it should be, or we hope it will be. And so you can use your dashboard, you can participate in the Registry Analytic Institute, and you can have custom reports if you desire. So this would be the surgeon dashboard. You can compare yourself nationally based on procedural data, complications and comorbidity data, and also patient-reported outcome data. And patients can use these portals to put in patient-reported outcomes as well as they like, which we think is a nice feature. And as I said, the Registry Analytics platform has been launched, and we really view this as a resource to the scientific community. We have some fellows, and there is a cycle by which you can apply if you want to get an external data request. Cycle 2 of the year has closed, but Cycle 3 is going to open on October 18th, and it will close on December 2nd. And you get an answer roughly 3 to 4 months later. So we have been very surprised with how much interest this has garnered in a very short period of time. Custom reports are just what they say they are. If you want to have something specific for your institution, we're happy to do that for you. So, why do sites participate? There are many reasons. So you can compare yourself to national benchmarks. We are not putting any regional benchmarks in there now for obvious reasons. You can get quality reports on your dashboards. You can look at your patient-reported outcomes. There are some payer-incentivized performance for things like Center of Excellence and Blue Distinction. You can use it for MIPS, as I said, and then certainly for the basic purpose of the registry, which would be surveillance of the metal and plastic. And we're always trying to decrease the data burden. We have lots of vendors that are helping us do this, and they are really essential for our mission. So if you have any questions, this is the website, registryinfo@aos.org, and these are our data elements. So we have the standard procedural data. We're trying to get away from level 1, level 2, and level 3 data. And we have renamed them procedural data, and then comorbidities and complications. And with the claims data from Medicare that we received last summer, we have more data on complications coming forth, which is very exciting. And then our preferred patient-reported outcomes are PROMIS 10, VR12, and Hoos and Coos Jr., though we will take anything that you give us, but they will not be analyzed. It's just those first 3 that we'll analyze. And the data elements for shoulder and registry, which has been launched, are similar, and same for musculoskeletal tumor elements. Each of these registries have different needs than hip and knee, but there are a lot of overlaps, and we certainly have some synergy with them. So, all right, just to give you a snapshot of what's going on in California. So we're the only state that has our own report within the registry, and that has to do with the fact that the California Joint Replacement Registry, started by Kevin Bozick, was essentially folded into the American Joint Replacement Registry several years ago. So they still allow us to do this, which I think is useful for the California stakeholders. So just to show you some highlights, as of last year, we had roughly 50,000 cases, so it's 30,000 knees and 20,000 hips from the state of California. Most of these are medium hospitals. And you can see what your participation rates are by institution. And we have a robust patient-reported outcome platform. We were the first ones to do this in California, so they continue to do this for us. But as you'd expect, you'd see improvement for WOMAC hip, WOMAC knee, and you can actually see your rates of improvement compared to others. We get a lot of questions about this, but generally all positive. And here's WOMAC. I won't go through all these, but you can see people want to see their data, and they want to importantly see their data in action. So you can see all that. And here's physical component for VR12, and you can compare yourself to national benchmarks. And here's for the mental component of VR12. And again, you compare yourself to other hospitals. A lot of this is just descriptive, as is what we have in AJR at this point. That'll change, but you can see here's age distribution comparing revision and primaries in California, pretty similar. And this is for revisions, not any surprises. Generally a little skinnier here in California compared to the rest of the country. It's a good thing. The diagnoses are very similar to the rest of the country. For revisions for knees, it's essentially infection, loosening, and then stiffness and instability. And for hips, it's essentially disability, infection, and loosening. Our length of stay for primary hips is a little bit better than the rest of the country, and it's a little bit worse for knees, which doesn't make a whole lot of sense to us, but it is what it is. And we tend to have less comorbidities than other folks. So it's nice to be able to get a snapshot of what's going on in California as well. So let's get down to some specifics, and it's really hard to answer this question, but I'll try to shed some light on it. So I'll use a snapshot of AJR data from 2012 to 2017, and this is from last year's annual report. And I'll say that AJR definitely plays a role in these trends. It's probably a small role because of the fact that the registry is fairly immature, but surely it's going to increase in the future, and we're already seeing that with increase in participation. And we know the majority of the trends that we currently see in AJR have really been driven by dissemination of best practices from international registries, multi-center studies, and various educational offerings. So we'll go through just some of the figures, and I'm not going to delve too much into the reason for my opinion on whether this is a good thing or a bad thing. If you want to, that's fine. We can do that in the Q&A, but I'm just going to give you a thumbs up or thumbs down whether I think the trend is good and indicative of whether we as a whole community are listening. So this is just a distribution of procedures. This is 1.1 million procedures, and about 55% knees, 32% hips, 4% hemiarthroplasty, about 4% revision knees, about 3% revision hips, and then hip resurfacing is hanging on at 0.7%, but pretty steady over the last couple of years. So I think first and foremost, the first thing you want to know from the registry is, are we decreasing the revision burden? It's been shown in many specialties throughout healthcare that if you just tell the doctors that you're measuring them, they're going to change their behavior regardless of whether they have seen the results of the measurements yet. It's been shown in cardiac surgery, it's been shown in OBGYN, and it's now being shown in orthopedics across the world. So I think this is a really good sign. So hip revision burden from 12 to 17 went from 12% to 4%. So that's really, it's a 300% decrease. Granted, we have tens of thousands of revisions in the registry at this point, but these are linked revisions. Okay, so not everybody who has a primary in an AJR hospital is going to have their revision done in an AJR hospital, so you need to interpret the data through that lens. The reduction in knee revision burden isn't quite as much, so 8% to 5%, but that's still on the odds of 40% over 5 years, so I would say that's very positive, and we are listening there. I think most of us in this room would agree that for somebody who has a fractured neck or their femur, if the surgeon was able to choose between a total and a hemi, they would do a total. I don't really think the data is controversial on that, but from a workforce issue, that's not really possible. So if you look here, you can see a small decrease in the numbers of hemis that are done and a slight increase in the number of totals are done. So I think that's a good thing, and you can make the argument that people are listening to the data there. How about percentage of cemented stems in hemiarthroplasty? From international registries, you can make a very clear argument that cemented femoral fixation is just as good as cementless femoral fixation. May not be true here in the United States due to practice trends and familiarity with cementless fixation, but anyways, we would expect to see more cemented fixation as patients get older with hemiarthroplasty, and that's indeed the case, so that's a good thing. How about unipolar heads for hemiarthroplasty? Everybody knows there are bipolars. They were marketed for increased range of motion and should provide increased stability, but there were problems with the junction and the wear of the polyethylene bearing. So most of us use unipolar heads if you're going to choose a unipolar. And you can see here by patient decade of life, unipolar usage is going up, and that's probably a good thing. How about hip resurfacing? So we're down to 0.4%. It's only 380 cases. And I would say for the most part, that is a good thing. Composition of femoral heads, we'll spend a minute on this. So with mechanically assisted crevice corrosion being a problem and that being attributed to many factors, amongst them the size of the femoral head, that led to a change and increased adoption of the use of ceramic heads. And you can see here from 12 to 17, you have an increase overall of all cases in the registry of the use of ceramics and a decrease in the use of metal, so I think that's a good thing. If we look at the actual sizes, you can see on the top there, those are 36 heads going up, and that's probably coming at the expense of the 32 millimeter heads, and that's exactly what we see. The bump there in the blue line is the 28 millimeter heads. The reason those are going up is probably because of their use in dual mobility. And you can see 40 millimeter head usage is going down a little bit, which is probably a good thing. The increase in impingement-free range of motion from 36 to 40 is probably not enough to justify the risk of mechanically assisted crevice corrosion. And this holds true with the survivorship curves. So on the top, those two lines are 32 and 36 millimeter heads, and they have improved survivorship. Granted, it's not a huge amount. Look at the scale. It's only 0.92 to 100, but 32 and 36 are certainly outperforming 28 and 40. As you'd expect here with 40 millimeter heads, if you look at ceramic of the blue and cobalt chrome is the red, you see improved survivorship with the ceramic 40 millimeter heads. That's not a surprise, and that's informing some practice. And then interestingly, if you look at just the 36 heads by composition, you see pretty similar curves for survivorship for ceramic versus cobalt chrome. Most of us expect these curves to diverge in the future, but again, head composition is just one of multiple factors that may influence this, so stay tuned. All right, let's go on to the liners now. So this is cobalt chrome versus ceramic in terms of the percentage usage of antioxidant liners, and you can see the antioxidant group is the orange, and they are increasing steadily, both in the use of ceramic heads and cobalt chrome heads. And if you just look at the use of these liners with disregard to the head type, you can see those blue bars, those are the antioxidant stabilized polyethylenes. Those are increasing each year, and I don't think in the first decade of usage that it's going to make much of a difference, but we may see one in the second, and stay tuned because we need more data on that. But this is what I would expect, and I personally think this is a good thing. Let's look at cemented and cementless stems for primary total hip arthroplasty by decade. As I said, for older patients, you could certainly make an argument on the cost side that they should be having a cemented stem. As we'd expect in the older patient groups, we're seeing more cemented fixation, so I think that's a good thing. Let's look at dual mobility. The emerging data are suggesting that dual mobility is a good thing for reducing instability, both in primaries and even more so in revisions. And in the United States, you can see here dual mobility both in revision in the orange bars and for primary in the blue bars is increasing. And then how about use of modular necks? So just look at the N. So it's not a lot of cases. It's 6,000 cases over 5 years, but this is a little bit of a head scratcher for me. We're still seeing an increase in the use of modular neck stems the last 2 years, and I would make the argument that these are unnecessary and they reduce an additional interface that could lead to mechanically assisted crevice corrosion. And if it's not really that necessary, you probably shouldn't be using them, and we're still seeing them increase. But we'll have to see what happens in the future. So I would say that's a bad thing. What about mobile bearings for all knees? There's very limited data to suggest that there's improved survivorship with mobile bearings in the primary setting, and the usage there has increased a little bit since 2014. That's the blue bar in primary, so that's, I would say we're not really listening to what the data shows. In the revision setting, this mobile bearing type of device is probably a good thing to offload the stresses at the fixation interfaces a little bit. And we're seeing increased usage of that type of bearing surface, and I would make the argument that that's a good thing, assuming that it doesn't cost too much more. This is a little bit of a head scratcher. Percentage of unis compared to all primaries is going down, 1.8% compared to 6.7%. So the perception that in the appropriately selected patient that the uni feels a little bit better because they have more of their normal knee and their survivorship should be similar to a total knee would lead you to argue that the use of unis should be the same or going up, not going down, but it is going down quite a bit. And we could discuss that further. My opinion is that patellofemoral arthroplasty works well in the appropriately selected patients. That's certainly controversial. There's no question these patients do well with a well-done total knee arthroplasty, but this hasn't really taken off, and you could make the argument that in the appropriately selected patients, it's probably a better idea just to replace the part that's affected, but we're not seeing that in the registry. And then look at bearing surface type in knee replacement. As one would expect, the use of antioxidant polyethylene, which is the gray curve there, shows a increase from 2.5% in 2012 to 25% in 2017, and that's coming at the expense of decreased usage of highly cross-linked polyethylene and even conventional polyethylene. So my opinion here is this is a good thing, and so I would say we are listening, but obviously that's controversial. And then if you look at the survivorship data by tibial insert, the antioxidant polyethylene, which is the blue bar, is doing the best. But again, you need to pay attention to the scale. These are differences of 1% and 2%. So that may be statistically significant, but the clinical significance of that needs to be determined. And patella resurfacing in the United States is pretty steady. You see 94% to 91%. That is a large topic that is beyond discussing entirely here, but for the most part in the United States, you're going to get your patella resurfaced. So I would say anecdotally, there's definitely increased interest in less resurfacing. And then lastly, we'll stray a little bit from the U.S. registry, but one of the things that I think is a good thing is the use of surgical navigation, and we'll have a session on that tomorrow, or later today actually, but I won't delve too much into this, but I've been using navigation on all my cases for the last 4 years, and I think it's a great teaching tool, and I think I do a much better knee because of it. Despite that, the uptake in the United States is up to 5% only. In Australia, it's about 35% of all knees are done with navigation. So there are definitely data to support that. So this is from the Australian Registry, 2015, and it's 44,000 knees. And for all-cause revision in patients less than 65 years of age at 9 years of follow-up, the revision rate for the non-navigated knees was 7.8, and for navigated it was 6.3. So that's showing favorable survivorship. And that improvement is further magnified if you look at patients less than 55 years of age. This is a 25% decreased revision burden, and this in part explains why navigation adoption in Australia is over 30%. But again, in the United States, we're not seeing that, and if you look at these numbers in a different way in terms of reduced revision rate for patients less than 65, it's 33%, and for even those greater than 65, it's 25% reduced revision rate for the use of navigation. So on navigation, I don't think we're listening too much, but more to come on that. So in conclusion, are we listening? Yes, most of the time. We certainly could do a better job. I think we should listen more closely in the future. And I would just make a plug for the American Joint Replacement Registry. We do have 2 new steering committee positions coming online that you can apply for through the CAP process starting next month. And if you're interested in getting involved, please do. Thanks very much.
Thank you, Hutch. That was incredible work. Next, we have Tom Barber talking to us about what's coming out of Washington other than the tweets. Maybe a little deeper look at that.
Just a few tweets, and there's not a lot happening in Washington these days, so we'll make this pretty quick. So, first, I'm going to talk both about the legislative and regulatory issues that are coming out of Washington, D.C. And one of the things for all of us to recognize is that in years past, the legislative things tended to rise to the front because it was what's reported on, what everybody worried about. But I think as the Academy has understood, and how many of us understand, is that most of the changes that actually affect our practice are coming from the regulatory side of Medicare primarily, and other arenas. And that we really have to pay attention to what's happening in the regulations, because that's what some of the bundled payment programs came out of. That's what some MIPS and MACRA have sort of come out of. They were legislative as well, but a lot of the detail that really affects our practice is really from the regulatory sphere. So I'm going to talk a little bit about both. And the clicker... There we go, got it. Okay. So as far as legislative activity in the last year or two, there are a few things that have floated to the top, and we'll talk about these individually. One is opioid legislation. Clearly, there's been a lot of concern about the opioid crisis in the United States. I think many of us would argue that sometimes the pendulum has swung a little bit too far, and making it more difficult to provide pain medication for our patients where it's needed. There was a delay in the Cadillac tax, which is the high-end health insurance offerings that people had, repeal of the individual mandate, and expanded health insurance association plans, which has made a difference. We'll talk about each one of these in turn. And so let me talk initially about the opioid, and then pending legislation is surprise billing legislation, which we'll talk a little bit about, and what the Academy is doing in that regard, and where we're headed with all that. And the regulatory changes, we have total knee replacement changes, total hip proposed to be off the inpatient-only list, and price transparency, and encourage telehealth. So, oh goodness, we're missing a whole bunch of slides. So let me go back and talk out of here. I don't know what happened to those slides, but we can talk a bit about this. So as far as the opioid legislation, I'm going to go back there. There was a legislation passed about a year ago that did a number of different things. They provided additional funds for treatment centers, especially to get some of the poorer patients treatment for opioid addiction. That was a big deal. They also helped push along some of the state initiatives, such as the Cures initiative in California, that changed so that we had to check the database prior to prescribing medication. That's been implemented as of January in California. I'm just sort of curious, how many of you 100% of the time, or as close to 100% as you possibly can, check Cures when you do your opioid prescriptions in California? Okay, so it seems like a minority of people. I think there's some challenges to that implementation, one of which I think is the changes in the passwords that have occurred rather dramatically. So that's kind of interesting. And I think that there were no radical changes with this opioid legislation. It basically provided more funding for treatment. It provided some support for state initiatives, and it provided some oversight to some of the opioid processes that were going on, such as the Cures initiative. I'm going to get, Stefano, could you bring my computer up just for a second? Because I just want to double check the slides. I know I've got a lot of information. I'm sorry, a bunch of them are missing. I don't know how that occurred. So let me just, I just want to make sure I have all the data. Thank you so much. This can help me just a little bit as far as where we're going. So the other things that the opioid legislation, I didn't finish with a couple of these, expanded the treatment workforce rather significantly. So that really helped with student loan repayments for those going into opioid addiction treatment. So that helped in that regard. Next, as we go, give me 2 seconds. The other things that we saw were some of the Trump administration changes to the ACA, and I think this is important to recognize what's gone on legislatively. The delay of the Cadillac tax by 2 years so that the very expensive, very comprehensive health insurance plans, they were supposed to be taxed to make sure that employers weren't offering plans that were over and above what people thought was appropriate for health insurance. That's been delayed to 2022, so that was one of the changes. The elimination of the individual mandate starting in 2019, so there's not a mandate now from in a financial sense to maintaining health insurance. That was a change. And one of the big ones that has become in sort of under the radar that I haven't seen a lot discussed, but it's making some major changes, is the expansion of association health plans. So that's small business owners banding together to buy health insurance at a lower rate. And in some cases, that has meant that they've gotten health insurance that is skinny, if you will, and has a lot of deductibles and things that the larger employers wouldn't necessarily put up with, but it's changed some things in that realm. The surprise billing legislation I do want to talk about because this has been a big issue and has gotten a lot of press. So surprise billing really occurs when a patient receives a bill for an out-of-network service that they didn't expect. It could be a non-contract anesthesiologist, it could be a non-contract hospital, and you're contracted with that physician. There have been a bunch of high-profile cases. One that's been noted a lot was a teacher who was charged $109,000 after a heart attack because they had an out-of-network provider that was there. There have been a bunch of public events that Trump has been bringing together folks from around the country to really discuss the surprise billing issues that have occurred. And I think as you look, there are a couple of different models that are being considered presently. One that the Academy is really pushing is a model that's called the New York model, which is essentially holding the patients harmless and setting up an independent dispute resolution process. This allows, both physicians to charge what they think is appropriate and hospitals to charge what they think is appropriate, and the insurer can offer something, and then there's a resolution process that decides which one would be most appropriate, sort of like a baseball-style arbitration, if you will, between the physician's bill and the offer from the insurance company. And the arbiter has to choose one, with the loser paying the arbitration costs. So that's what the Academy is pushing right now. However, the most favored model legislatively right now is basically price fixing at the federal level. And insurers are really pushing for that, which would allow, I'll give you an example that would be the extreme side of that, is setting the rate in a surprise billing case if there's no contract at the Medicare rate. Well, that doesn't give you any leverage as a physician because the insurance companies may say, oh, we just don't want to contract for those services, so we won't do it, therefore we're just going to pay Medicare rates, and that would satisfy everything. So I am very concerned that that might pass, and I think the Academy is. There's been a lot of effort on the Academy's part to try to get legislators to understand the impact that that would have and how it would significantly decrease the power of contracting for physicians and hospitals. So hopefully that won't pass. That will be up in the next few weeks for a vote if they can get consensus on one way or another. So we'll see. The other things that are, that's the Senate Health, Education, Labor, and Pensions. The HELP Committee has been pushing that solution. On the regulatory side, I think there are a number of things that are really important to think about. The first one I want to talk about is total knee replacement and what's happening with that. So I think that it was removed from the inpatient-only list about a year and a half ago, 2 years ago. That was meant to allow people to do total knees in a setting where it didn't require a 2-midnight stay. That has been very confusing because at the same time, Medicare did not approve it for outpatient payment. So you couldn't get paid, from a physician level or a site level in an ASC, even though it was off the inpatient-only list. And it did provide a window where the RAC, where you couldn't get audited for the inpatient versus outpatient designation in the hospital, which was an advantage. But I think what's happening with total knee now is that as of January, it is almost certain the rule has been released but not finalized, that outpatient payments will start going through in January for total knee replacement. So it's going to be possible from a Medicare standpoint to get paid in an ambulatory surgery setting, which wasn't possible before that. So that's starting January of next year. With the total hip replacement, what's happening there is it's been proposed to remove from the inpatient-only list this coming January as well. However, they won't make the outpatient payment deadline at the same time as total knee. So most likely that would be another year after. So we'll have another confusing year where it's not an inpatient-only procedure, and yet there's no way to get it paid for in the outpatient world. So there's going to be some confusion there, and that probably will also be safe from RAC audit for a couple of years. One of the key elements of Trump's plan was transparency for healthcare providers. And how many of you have actually checked your facility's websites that as of January were required to post all pricing? Has anybody checked your local sites? So that's how well transparency is working. Not a single person here who has an interest in it has checked. I actually checked the UCSF public site just to see what they were posting for the charges for total hip and knee. I'm just going to read them to you because this is publicly available on the website, and it was part of the initiative from the Trump administration to really get people to think about costs and how they might be moving forward. So just think about these charges as they're listed and think about whether this might change your approach to getting a hip replacement or a knee replacement if you're doing that. So first one, inpatient 466 revision, this DRGs, revision of hip or knee, charges UCSF $283,000. 467, $188,000. 468, $130,000. 469, $200,000, and 470, $105,000. What I would say is I wish UCSF got that kind of money. That's not happening, but these transparency initiatives are interesting, but will be fraught with these kind of dangers because I am sure that almost every facility out there has done something similar as far as the charges. So it's just interesting to see where that goes. But there will be more of an effort for transparency on the physician side as far as payments, as well as on the providers, on the hospital side, so we'll see that. So the future, where are we headed as far as regulatory changes? We talked about a couple of these things with total hips and total knees. I think that the future right now, we're going to see further transparency rules and what that means, whether it's transparency of charges, transparency of cost, because they're very, very different things, or transparency of reimbursement, which is a whole nother scheme. We don't know. I think there'll be more in terms of the opioid prevention rules. We're seeing a lot of people get more into that space. There's going to be more regulation and rules. I know Medicare was really pushing a measure that hospitals would be judged upon that would be a combination of anxiolytics and opioids. So when you're having Valium in conjunction with an opioid, that would be seen as a very negative thing. And the Academy had a lot of comments on that because they basically wanted zero opioids prescribed when somebody had, a Valium type substance on board in their standard prescriptions. And they were going to judge hospitals based on that. Well, imagine, all of your patients coming in with fractures to the ED who are already on Valium not being able to receive any opioids at all. That would be a problem. So there are things that are happening in the regulatory sphere that might make it more difficult. However, I think the Academy is watching out for those things, and that particular measure is not going to go through, but it almost did. Legislative priority is the surprise billing, and that's the major issues here. Anyway, that's it. I really apologize for my slideshow not coming through completely, but I think I got through the material, so thank you.
Thank you so much, Tom. So we are just on time for lunch, but since, and I could go on this topic for hours, but in the interest of keeping us on time for lunch, I'd like to just invite the audience for 1 or 2 questions, and then we'll break for lunch to keep us on time.
Nobody else? Chance, I just have a question for you. I appreciate the enthusiasm around bundled care. We've, from the payer perspective, we participated in it because we wanted to understand it, experience it, and there is enthusiasm because it's taking costs out for the payers. My question for you, though, is I look at this abundance of evaluation and other providers getting engaged in the episode of taking care of a hip or a knee patient. What is your impression about the overall costs? My impression is that we're bearing a greater cost as the provider that's not being captured in this enthusiasm about taking costs out of the system. And what is your thought on that?
Yeah, that's a great question. And there's actually been some recent data speaking to that. So Max Courtney, who is part of Rothman Institute, has published a couple papers in the last 6 months showing that physicians now are actually increasing their amount of effort that they're expending, not just in terms, not surgically necessarily, but conversations with families to prevent admission to a skilled nursing facility. Even as we've shifted to outpatient care has been cheaper, but you probably spend more time as the surgeon with your patient on the day they have outpatient surgery than you would if they had a 3-day hospital stay, because you check them in the PACU, you're talking to family. So there's certainly a recognition on the surgeon side that there's increased burden and probably cost to the surgeon. The argument that people would make, I think, from a bundled payment side is that is the why the gain sharing model is so essential. So if you are cutting your Medicare SNF discharges by 70%, you're saving Medicare a ton of money. That money then should flow back to your practice or to the physician in some way as an acknowledgement of your increased effort. That has been legislatively made possible, but each practice and institution handles that differently. So I can tell you personally, we have not been successful in establishing gain sharing. So we saved our hospital about $2.5 million over the last 2 years, and we have gotten zero of that back to the practice. So I think that's certainly a risk, and it's something that is going to have to be carefully navigated, I think, by all the people involved.
Yes, just to speak to Tad's point a little bit more. So, Tad's hypothesis is that the value is going up and the surgeon's reimbursement and efforts are going in the other direction. There are some data that will be coming out shortly from a gentleman named James Brown, who works at the University of Virginia, which will show both for hips and knees very nicely and very clearly over a decade that surgeon reimbursement has gone down, and by a magnitude, hospital reimbursement and insurance company reimbursement has gone up 5-fold. So that's going to actually quantify the problem, and what Tad's getting at is how do we fix this? And I can't tell you that I have the answers, and unfortunately some of the answers we're not actually able to discuss because of antitrust issues, but hopefully there'll be more to discuss on that in the future.
One last comment. Knowing from the Medicare standpoint, what they're saying is that we actually are put in there, our payment is based on a 3.5-day stay in the hospital presently. And so what they're saying is we have less rounding to do because the patients aren't staying in the hospital, so that should make up for the additional work. I don't agree with that, but I'm just saying that's what they say.
One question for Dr. Barber. We heard a lot about the total knee coming off the inpatient-only list, total hips set for January 2020. My fear at our hospital is that we're dichotomizing this. So outpatient surgery is same-day surgery. inpatient surgery is now defined as 2 midnights in the hospital. So all of the hospitals that are doing a good job of lowering lengths of stay down to maybe the single days, 1 night, that patient's left out, and that scenario is left out. So are you hearing anything in Washington of adding a 3rd category? We can call it whatever we want, but the hospitals and providers are not getting compensated for their 1 night stay for total hips and total knees, right?
Yeah, no, I agree. I think that it's put a lot of additional burden on us, again, to Tad's point, is the documentation. Because they gave us that window, if you will, from the RUC, you can still charge for an inpatient stay if they don't stay 2 midnights, but you have to document that they expected to stay, 2 nights, which is a challenge. But you can do that and get paid for it. But that's not a solution. That is a stopgap measure for us to do that in the interim. You're right, there is a challenge in that, and I don't know a solution.
Yeah, hopefully my fears won't be realized. That's the direction our hospital took, was making our documentation more robust of the patient that's status post-kidney transplant or whatever needs to be charged as an inpatient. But as we get better and they go home 20 hours later, so I'm very fearful for our hospital when 2020 the RAC audits are coming back around, and hopefully they don't choose Denver.
So just a few comments on that. I think everybody needs to be very clear that that this is not about rational thought, and it's not about doing what's the best thing for the patient or the doctor or the hospital. This is about saving Medicare money, and it's only about saving Medicare money, and it's disguised by many things. The preliminary estimate right now is that in the year 2018, Medicare saved by taking total knee arthroplasty off the inpatient-only list. And despite many calls from AUKUS and the Academy to rectify the situation and to provide clarity, they've refused to do so, and the savings are estimated to be $968 million for the calendar year 2018. Some of you heard Gavin Newsom this morning in response to one of many things that the president said yesterday. One of them was comments on rolling back auto emission standards by the state of California. And Gavin said this morning that let's be very clear about this. This is not about your health. It's not about clean air. It's not about cost. It's not about doing the right thing. It's about the oil companies' lobby and nothing more than that. So just be careful as you sift through this. Don't understand what the overall goal is here.
Actually, I was going to ask you to go a little further and talk a little bit about the RUC process. You mentioned it yesterday or the other day, either one of you, and what just is happening right now around how the evaluations will be done for the procedures.
Yeah, for total hip and knee, the RUC evaluates how much work goes into actually performing a total hip and knee. That's based on audits from various practices around the country who are volunteer for or are volunteered to have those audits. And to a large degree, if I remember correctly, I think it was 32% of the fee under Medicare for total hip and knee was based on time spent in rounding post-operatively. And that was based on a 3.5 length of stay, 3.5 days. So if the length of stay goes down to 1 day, you could expect rationally to see up to a 25% decrease in reimbursement for total hip and knee. I don't think that will happen, but the RUC is evaluating that based on information that's come back from practices that they've audited. And if they're auditing practices, like some around the country where the length of stay is 1 day or around that, it's going to come back to hurt us in the long run.
Yeah, just let me clarify that a little bit. So, by way of disclosure, I serve as the Advocacy Council Chair for the American Academy of, or American Association of Hip and Knee Surgeons, and I've been leading the effort on the AUKUS side for this, and I am bound by some confidentiality rules associated with the RUC process. But in about 2 weeks, we'll finally have an answer to this process that's gone on for a year. So the way that work RVUs are determined, there's 3 inputs. It's roughly 49.5% time. It's 49.5% practice expense. And then there's a little bit of medical or legal liability, which makes up the other 1%. The request for reevaluation, which was put through by Anthem and rubber stamped by CMS, was based on our time. And I will say that in our survey efforts that were completed in August, we had a robust survey response. The survey results, specifically with regard to intra-service time, were very favorable for us maintaining our values. So we've submitted our official recommendations based on the survey. Yesterday, we received the reviewers' comments from the RUC, which is essentially going to determine how things go at the table discussion, which is at the beginning of October. There are some holes in our argument that are very small, and as expected, the reviewers picked up on these, but I think we are in a good position to defend them. So in summary, I would say from a scientific standpoint, we stand on very firm ground, not to have any devaluation of our services whatsoever, and actually from the science standpoint, we could have increase in payment, though we're not asking for that. That being said, there's a clear mandate from the RUC through CMS that costs need to go down, and we have the biggest target on our back because we are amongst the highest cost centers for CMS. So again, this is not necessarily about data or rational thought. This is about economics.
Thank you for bringing up that last point. That's the one I was hoping you'd bring up, that it's not, it really is, we just happen to be the largest targets. It's easier to achieve the goals by decreasing a percentage of the largest pot than it is to go get small amounts from smaller groups that are not financially rewarded as much.
All right. Thank you all very much. I
Thank
think
you guys.
we should
Derek, just
break
want
for
to
lunch.
can I just say thank you both to both you guys, because you both served in that capacity, one for AUKUS and for Academy, because it's work that none of us have had the time to do, but that you guys have done to represent our needs and our group. So thank you for that.
Absolutely. Took the words right. Thanks, Steph. So we'll break for lunch. We'll return back, so we have time for lunch promptly at 1:15, so 5 minutes late for our next session. Thank you all.